Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Intellia Therapeutics.
Hi, I'm Dr. Daniel Sotiris, Associate Clinical Professor of Medicine in Allergy and Clinical Immunology at the University of Colorado, here in Aurora, Colorado. I also have a private clinical practice in Colorado Springs. Welcome to this program titled Inside the Edit, Lessons from the Field and Emerging Implications for HAE, Hereditary Angioedema. Joining me today is Dr. Autumn Burnett, Assistant Professor in the Division of Allergy and Immunology at Howard University in Washington, D.C. Before we move forward, I want to go back a little bit. Dr. Burnett, Autumn, we go back a long time. We trained together in New Orleans 20 plus years ago. I won't say exactly how many years. It has just been a pleasure working with you in the hereditary angioedema space for the past 20 years. So forgive me, but this is kind of a full circle moment for me. And I just want to say thanks to Medscape for pairing us up. I've enjoyed your intelligence, your wit, and your contributions in this space. Welcome, Autumn.
Thank you so much, Danny. It's great to be here with everyone through the Medscape portal. So let's get started.
Great. Today, we're discussing long-term prophylaxis therapies for hereditary angioedema. We're going to divide this into three parts: past therapies, today's advances, and what's next on the horizon for HAE treatment. So, Autumn, let's start by looking back at the early long-term prophylaxis options. Can you take us through what we had in the past and the limitations we faced?
Well, before there was any FDA-approved treatment, we were limited to oral attenuated androgens. Now, we know that there is an adverse side effect profile from oral attenuated androgens, so it was very welcome. Around the year of 2000, I would say 8 or 2009, the first FDA-approved treatment was IV C1 esterase inhibitor treatment every 3 to 4 days, which again allowed us to really treat these patients in a very targeted way. We were limited, obviously, by dosing intervals of being every 3 to 4 days and having an IV medication in terms of the route. Following that came the subcutaneous treatments. We are familiar with subcutaneous C1 esterase inhibitor protein given every 3 to 4 days. We are familiar with monoclonal IgG antibody, lanadelumab, that allowed for inhibition of plasma kallikrein administered every 2 to 4 weeks. We are also familiar with oral berotralstat, which allowed for inhibition of plasma kallikrein delivered on a daily basis. Some of these medications that we are very familiar with, we were limited, maybe possibly from efficacy, possibly from painful injections, possibly just from frequent injections. I think that there was room to improve in terms of possibly route, possibly efficacy, possibly the tolerability of these medications and dosing intervals. So, the new space, I think, as it exists now, as of 2025, is giving us more options, I think, than what we are used to. Now, granted, having said that, the entire treatment landscape as it exists, I think, is now fairly robust and gives patients many, many options now.
I love it. That's a great overview. You're right. The oral androgen therapy, IV and subcutaneous injection therapies, oral therapies. This question also made me flash back a little bit because you were in the room when it happened. Company very proud of their development of a new long-term prophylaxis therapy, and all the advisors, said, thank you very much. That's great, but we need more from you. And we asked for pediatric approvals. We asked for less pain with injections, less frequency of injections. and companies continue to move that science forward. So, coming to the current state of therapies, we have more options that are more targeted and require less frequent dosing, but durable control remains elusive. Autumn, what are your thoughts about durable control?
Well, I think, you know, the durability, I think, and the consistency of medications, not only working in the initial phase of using the medication, but for the long term. I mean, again, this is long term prophylactic therapy. I think it is really important for patients to know that there will be durability, consistency, stability of their response. I think that, they would ideally not like to have breakthrough attacks as much as possible. They want to get their quality of life back. They want to, go to weddings and go to, travel around the world and feel that they don't necessarily have to depend solely and heavily on rescue therapy. They want substantial attack reduction, and they want that attack reduction to be consistent and durable for the long haul.
Right. When I think about this, if I had to just give a one word answer, I would ask individuals to think about a major trigger for HAE is stress. We don't have a pill for that. Stress is going to happen. So, next, I divide it into extrinsic and intrinsic factors. Extrinsic factors, exactly what you outlined. Life is happening. You've missed a dose. You have work conflicts, family needs, insurance changes. Sometimes people have side effects from medications that are adverse. There are intrinsic factors. Uh, One thing on the science side, we don't really have a biomarker, a lab test that tells us one therapy will work better than another therapy for individual patients. And then there are these big topics like genetic penetrance, where you think that even within a family where there's the clear documented family history of the disease, one individual might have low activity, another individual has high activity of the disease. The science is working really hard to help answer these questions about adherence, missed doses, tolerability, the impact on quality of life, the disconnect between clinical measures of control and the heterogeneity of the disease. So the science is working hard to help with adherence and tolerability. Um, I'll also say we have a health insurance system that is flawed too, and this is a source of significant stress for many patients. The pharmaceutical industry continues to have progress in helping patients with different programs, but they don't work for everyone. And every time they make a change, the health insurance industry makes a change. Looking ahead, we see a pipeline of emerging long term prophylaxis therapies. Autumn, let's discuss where these agents fit along the kallikrein bradykinin pathway. And here's an outline of the pathway. It's that classic pathway from factor 12 through the high molecular weight kininogen, the prekallikrein and kallikrein, and then that release of bradykinin responsible for vasoactive peptide responsible for vasodilation, leaking fluid, and the swelling events that we know happen with hereditary angioedema. So, walk us through the most recently approved long term prophylaxis therapies.
Well, 2025 was a good year for HAE. We had two long term prophylactic therapies that were FDA approved. The first of which was garadacimab, which is a monoclonal antibody that inhibits activated factor 12, sitting at the top of that pathway, the cascade that you just walked us through. The second that was FDA approved was donidalorsen, which is a novel treatment for the HAE space. It is an antisense oligonucleotide that targets prekallikrein mRNA. And so it kind of essentially degrades that prekallikrein mRNA so you don't build out that protein prekallikrein and essentially um, inhibits fairly at the upper level of that pathway, inhibiting kind of that uh, proteolytic cascade in terms of release of kallikrein or activation of plasma kallikrein and so forth. So I think 2025 brought us therapies, one of which extended out the dosing intervals. Garadacimab is once monthly dosing after a loading dose. Donidalorsen is actually every 4 or every 8 week dosing intervals in terms of the frequency of dosing. Both of these are subcutaneous, and both of these are citrate free, which citrate is thought to be associated with pain of an injection. So These are giving us potentially better tolerability if these are citrate free. It's giving us longer dosing intervals, still giving us that subcutaneous injection. We're not having to find a vein, and maintaining good efficacy in terms of the clinical data that has been shown with both of these molecules. So I think these were great additions to 2025 in terms of the HAE long term prophylactic space.
I couldn't agree more. Well, there's a few things on the horizon. So, could you walk us through this next slide talking about emerging agents? I mean, think about it, Autumn. When we started in this space, there was nothing FDA approved. Now we're at like 8 or 9 agents approved to help patients with hereditary angioedema. And the horizon shows one, two, three, four, five more things here that I think our audience would appreciate you going through with them.
So I'll just start by saying the pipeline is rich. These All of these molecules are still under investigation, and none of these have been FDA approved. But let's just start with navenibart. Navenibart is a monoclonal antibody that inhibits plasma kallikrein. Specifically with navenibart, this is a molecule that has a longer half life, so potentially allowing for longer dosing intervals, up to every 3 or every 6 months. So this is administered subcutaneously, and again, potentially allowing for that longer half life or potentially longer dosing intervals. So that is something that is in phase three trials currently and is in the pipeline. Let's go over to BW 20805. This is currently in phase two data right now. This is what is called a GalNAc conjugated small interfering RNA that inhibits specifically the prekallikrein um, generation. Again, similar to what we're kind of seeing with donidalorsen, which was approved in 2025. But this may also potentially allow for longer dosing intervals. Again, targeting that prekallikrein mRNA, degrading that prekallikrein. You're not building out that protein prekallikrein, and so looking again at these kind of molecules that are targeting mRNA, I think is unique now to the space of investigational therapies and what we already have seen with donidalorsen. Let's go down now to Lonvo-Z. Lonvo-Z is different from the rest. It is CRISPR-Cas9 based therapy that reduces plasma kallikrein. Now, this is administered as kind of a one and done, if you will. It's a one-time IV infusion. And specifically, the way that it works is CRISPR gene editing, allowing potentially to permanently lower kallikrein by inactivating kallikrein B1 gene with a single dose. So this is unique to the pipeline. This is unique to these investigational therapies, different from the other ones that we're seeing here, and really targeting the gene which encodes prekallikrein. Now let's go to onvozurasan, which is a small interfering RNA duplex oligonucleotide that inhibits prekallikrein generation at the mRNA level and reduces the production again of prekallikrein. So this is unique in that it can also potentially allow for longer dosing intervals up to 6 months. Again, targeting that mRNA of prekallikrein, degrading it, not building out that protein. So we're really looking at, again, another target of that mRNA, which is, again, something that we're now becoming more familiar with in the HAE space. And then finally, here we can see deucrictibant, which specifically targets the bradykinin B2 receptor, um, unique to the space of HAE in terms of prophylactic treatment. We have targeted the B2 receptor for on demand, but this is unique specifically to targeting the B2 receptor as a prophylaxis. This is an oral option. So this would be orally administered, again, different from the other medications and investigational medications that we see. This would offer an oral route. So for some patients, this may be a nice option if they are needle averse, or if they just want to use an option that is an orally administered route. Do you have any thoughts, Danny, about some of the investigational data that we have seen that has recently come out for any of these molecules?
Wow, Autumn, that was a fantastic job reviewing those very long names and complex mechanisms of action. Oh, the only thing I could add to what you had to say was there were some recent data presented on each one of these products. On vuzosaran, ADX324 currently is in a phase 3 trial. The phase 1 and 2 data showed sustained reductions of plasma kallikrein levels. The molecule BW20805 is an ongoing phase 2 trial. The data have shown good PKK suppression and support looking at a Q6-month dosing interval. Navenibart has phase 1b and 2 recently published in JACI, the Journal of Allergy and Clinical Immunology, and it supports looking at dosing every 3 or 6 months. Lonvo-Z, the CRISPR-Cas9 technology, has phase 3 trial demonstrated an 87% reduction in mean monthly attacks for patients receiving Lonvo-Z compared to placebo, with 62% of these patients attack-free over 6 months. And then Deucrictibant, the phase 2 chapter 1 study, long-term safety and efficacy, attack frequency were reduced on average by 92%, approximately half of participants being attack-free during the entire extension period. To put all this in perspective, I'd also ask people to go back a little bit into your basic science book and remember we have DNA, RNA, and then proteins. DNA is transcribed, the RNA is translated, and we produce proteins. Lonvo-Z is a DNA therapy. We've talked about several RNA-based therapies. And then for proteins, that's where your small molecules and monoclonal antibodies are blocking the effects of proteins all along the cascades on here. So that was an excellent review, and thank you very much, Autumn. So there are some misconceptions among clinicians and patients regarding gene-targeted or advanced therapies. Use of some of these technologies in other areas have been used as well. I think the number one question that patients and clinicians share is, does it work and is it safe? And you can add to those durability and reversibility. There's a very natural and emotional process that people go through when they choose a therapy to manage a disease. They're choosing for themselves, and in a case, in a disease like hereditary angioedema, they're often choosing for their family members. We, the prescribers, have a role to guide them through the choices, but they make the choice. Unfortunately for us as prescribers, and as we're guiding people through their cultural nuances and their choices, we have many other options to make available to them. Autumn, thank you for this great discussion. Really appreciate you being a part of this. And like I said, full circle moment.
This has been a great session with you today, Danny, and we just so excited to share this information with you guys. Thank you.
Thank you for participating in this activity. Please continue on to answer the questions that follow and complete your evaluation. Take care.